the whole time I was with Britain.
Hi, I'm Sonu Jain. It's my pleasure to introduce you tonight to our AAHS Hand in Hand webinar series. This one is in partnership with the Amyloidosis Research Consortium, which we are thankful for their sponsorship. And we're going to be talking about amyloidosis for the hand surgeon. And I'm going to introduce our moderator, Nikhil Agarwal. Nikhil, take it.
Hey, everybody. Thanks for being with us here with us tonight. Good evening, everyone. Welcome. Thank you for joining us for today's webinar. We're going to focus on a growing clinically significant topic in hand surgery, which is amyloidosis. As hand surgeons, we're frequently encountering patients with carpal tunnel syndrome, trigger fingers, and other conditions that may be related to amyloidosis. And now we're realizing more and more that we may be able to diagnose these patients with a life-threatening illness. Amyloidosis has been increasingly recognized as a culprit in patients presenting with bilateral carpal tunnel syndrome and these other tendinopathies. And a lot of times they're manifesting these syndromes before a formal diagnosis is made. There's now new approved treatments for this that Dr. Schulman is going to talk about that can be started early in the disease process, and this can delay some of the most severe symptoms of amyloid. So it's a great thing to be able to know about. And so tonight we're going to review the pathophysiology, some clinical clues, and surgical implications of amyloidosis for the upper extremity. We have three awesome speakers today who are experts in the topic. And just logistically, we'll probably do one or two questions between the speakers, but then a longer Q&A all the way at the end. So first, we're going to start with Dr. Schulman. It's my privilege to introduce Dr. Charles Schulman while he brings up his slides here. He's a distinguished cardiologist and corresponding member of the Faculty of Medicine at Beth Israel Deaconess Medical Center. Dr. Schulman's presence here today is especially meaningful, not only because of his deep clinical expertise, but because of his personal experience with the disease. Several years ago, Dr. Schulman underwent carpal tunnel release, and this procedure ultimately led him to a diagnosis of amyloidosis, and so he's been treated for this now. Dr. Schulman brings to us a dual perspective, that of a physician who's treated cardiovascular conditions for decades and of a patient whose journey underscores the importance of this multidisciplinary awareness. We're honored to have him here with us today to share his story and introduce us to this disease. Thank you, Dr. Schulman.
Thank you. Thank you, and good evening, everybody. The portion of my talk I've titled "The Hand and the Heart: When Carpal Tunnel Syndrome Can Diagnose Amyloidosis." Martha Grogan from the Mayo Clinic asked, when are numb hands a window to the heart? And dating back to biblical times, seek and ye shall find. So cardiac amyloidosis in the olden times, that is before the pandemic, but really 7 or 8 years prior, was always considered a rare fatal disease that required an endomyocardial biopsy for diagnosis and for which there was no treatment. That's not true anymore. The disease process, cardiac amyloidosis, has received new attention and a recognition of its importance. And in today's New York Times, the following article appeared, once a death sentence, this heart condition is finally treatable. Amyloidosis is a protein misfolding disorder. Proteins, in order to properly function, have to be folded in certain ways. And so as illustrated here, normally folded proteins can become misfolded and dissociated from larger molecules to smaller molecules to protofilaments to amyloid fibrils, which then deposit in tissues that have no ability to regenerate themselves, leading to functional compromise of those tissues and ultimately to death. I just wanted to show you this. because this is a histology of it, and you'll hear more about this. Uh, uh, Under Congo red staining, amyloid tissue stains bright red like this. And under the polarizing microscope, there's green birefringence, which is typical of amyloid. Now, a little bit about heart failure. You folks are not accustomed to treating heart failure, but I have been for years. And heart failure has now been divided into a number of stages. And symptomatic heart failure is really the tip of the iceberg, shown here. It really starts with misfolded proteins and then extracardiac amyloid deposits, such as carpal tunnel syndrome, spinal stenosis, peripheral neuropathy, orthopedic and other manifestations. So that would be stage A, or at risk for heart failure. Stage B would be structural heart disease, atrial arrhythmias, conduction system disease, valvular heart disease, of which this is not relevant for us, but left ventricular hypertrophy, which is stage B without symptoms, and stage C is with symptoms. Why should the hand surgeon care about amyloid cardiomyopathy? Because there are opportunities to identify red flag clinical clues for which a patient can be referred to cardiology or a heart failure clinic or one of the amyloidosis centers. So let's talk about this case. An 82-year-old man in 2020 had a previous history of hypertension and hyperlipidemia. In 2020, he presented for carpal tunnel release, but his history of carpal tunnel syndrome goes back to 2017, at which time bilateral carpal tunnel syndrome was noted. In 2018, an article appeared in one of the cardiology journals from the Cleveland Clinic, where they took 100 patients who were undergoing carpal tunnel release and biopsied them all, and 10% of them were positive for amyloid. So this patient requested that his hand surgeon do a carpal tunnel biopsy. Okay, so carpal tunnel release in 2020, and the biopsy was positive. With Congo red stain, as you see here, and birefringence, as I've already mentioned. An echocardiogram showed left ventricular hypertrophy, confirmed by cardiac MRI. A pyrophosphate scan showed grade 3 uptake, the most, and a genetic test was negative. And in 2020, the diagnosis of wild-type ATTR cardiac amyloidosis was made, and he was started on tafamidis. Today, in 2025, now 5 years later, he's New York Heart Association Class 1. The New York Heart Association classes refer to activity levels. Class 1 is asymptomatic, 2 is symptoms with normal activity, 3 is symptoms with less than normal activity, such as walking from the parking lot into the clinic, walking up the stairs, walking from room to room when it gets bad enough. But our patient here has none of that. As a matter of fact, he ran 2 miles yesterday, and he has no shortness of breath, has minimal edema, easily controlled. If you haven't figured this out yet, this is me. This is the story of my amyloidosis journey, as it's called. And I wanted to share that with you. Being both a doctor and a patient has interesting ramifications, which I'd be glad to share with anybody. So there are two types. Most of cardiac amyloidosis, 95% of it, is caused by one of these three types of amyloid. There are over 40 amyloid proteins, but these three contribute to 95% of cardiac amyloidosis. Okay, so one is what's called AL amyloid. There are about 2,500 cases per year, of which 50% of the patients have cardiac enlargements, and indeed that's rare. The other two types are both transthyretin or ATTR amyloid. One is hereditary, where there's an abnormal mutation. 3 or 4% of African Americans are carriers, it turns out, and 3 or 4% of African descendants who live in the UK are also positive, yielding about 120,000 US patients, and that's not so rare. And then there's wild type, or has been called senile amyloidosis. I personally object to the term senile, but it is prevalent in older people, over the age of 70, certainly, and over the age of 80. As a matter of fact, 10 to 25% of adults over the age of 80 probably have amyloid deposits in their bodies. That's, leads to a million people with this diagnosis. So it's not rare at all. And it's becoming more and more known, more prevalent, but a part of that is because it's better known and people are looking for it. As I said in the beginning, seek and ye shall find. The mechanisms of cardiac amyloidosis are as follows. This is a disease of misfolded proteins. In the case of AL amyloid, the protein factory of light chains are the plasma cells in the bone marrow. This is similar to, but not exactly the same as, multiple myeloma. The plasma cells produce light chains, that they dissociate, form amyloid fibrils, which leads to carpal tunnel syndrome and eventually cardiac symptoms. With ATTR amyloid, or transthyretin amyloid, the protein factory is the liver. Proteins are produced in what's called tetramers. Each one has 4 parts. They dissociate and eventually misfold and form amyloid fibrils. I mentioned that in the 2018 study from the Cleveland Clinic, that 10% of the biopsies were positive. This study was presented from the National Amyloidosis Center in London at the American College of Cardiology meeting this past March. They took 555 patients who were undergoing carpal tunnel release over the age of 50, either unilateral or bilateral, and 39% of them were biopsy positive. Of 116 patients tested, 28% of them were positive for cardiac amyloidosis. So, and it's very age dependent. So, over the age of 50, you see 60% of the biopsies were positive, but over the age of 70, especially men, 73% of them were positive. So you see that there are many more patients who are now known to have this diagnosis. And so how do we manage cardiac amyloidosis? Well, thinking of the diagnosis is the first thing. Confirming the diagnosis is the second thing. And the workup for cardiac amyloidosis is relatively straightforward. It's not complicated. You do serum protein electrophoresis. If there are light chains, you refer the patient to hematology oncology. If there are no light chains, you do a pyrophosphate scan. If that's positive, you do a genetic test, and it's either positive or negative for ATTR amyloidosis. So once you have a diagnosis, then you have to manage the heart failure symptoms when they are present, and manage arrhythmias that are present, and conduction disturbances with pacemakers as needed. But what I want to emphasize is that there is disease-modifying therapy. That is, drugs which lead to improved survival, less death, and less hospitalizations. Okay, so disease-modifying therapy. In the case of AL, it's chemotherapy. Is the first-line treatment. For some patients, it can be a stem cell transplant, and very durable responses have been noted with these two therapies. For ATTR, either wild type or hereditary, there are two types of treatment that are currently available. Stabilizers prevent the tetramer from dissociating. So they maintain the protein in the properly folded manner. Tafamidis has been available since 2019, and that's the one that I take and I have taken for the last 5 years. Acoramidis was just approved this past November. And then there are the silencers, which reduce the production of transthyretin in the liver by something like 85%. And vutrisiran was recently, March 2025, recently approved for treatment of cardiac amyloidosis. Why is earlier diagnosis preferable? For one thing, the drugs work better earlier in treatment. So this is from the ATTRACT study 2019, and patients who are New York Heart Association Class 1, that is fully active, had a 65% reduction in mortality, whereas New York Heart Association Class 3, very symptomatic, only had 16%. And these are survival curves that are available for these three drugs. And as you can see, the survival probability keeps getting better and better, even approaching age expected mortality. So carpal tunnel release is an opportunity to prevent heart disease. Okay, untreated amyloid deposition in the carpal tunnel over 5 to 15 years leads to cardiac amyloidosis with infiltration of the heart. And the hope is that by applying treatment at this point, we can keep the hearts normal. And so my take-home points are: cardiac amyloidosis is not as rare as once thought. Carpal tunnel syndrome is a red flag for amyloidosis, as are some other non-cardiac manifestations. Remember to ask, could this be amyloid? Biopsy with carpal tunnel release is easy and affordable. Disease-modifying therapy is here, and early diagnosis and intervention leads to better outcomes. Thank you very much.
Thank you very much, Dr. Schulmans. Those positivity rates are always very impressive and get more and more impressive with every upcoming study. So while Dr. Galati is pulling up his slides, I'll introduce him briefly. He's the research director at the Curtis National Hand Center and scientific director at MedStar Union. Academically, His work's been supported by grants at the NIH, DoD, and our surgical societies as well. We're honored to have Dr. Galati at this webinar. He's a true scientist, unlike most of us in hand surgery, and we're lucky that he's studying this disease as well. So thank you, Dr. Galati.
Thanks for the overly kind introduction. I'll make sure you're seeing the slides proper. If not, Nikhil, just let me know real quick. Otherwise, I'll get started. So
they look great.
yeah, perfect. Thank you. All right. So some of the slides will have a little bit of overlap from what you just heard, but I'm going to try to now home in a little bit on the focus for the hand surgeon, referencing some recent literature and kind of review the background a little bit again. These are the slides are a combination of what's been published focused on hand surgery and some of the background where I have to thank my cardiology colleagues, Drs. Vora and Sheikh, who worked with me at the MedStar Amyloidosis and Heart Failure group. So again, you all just heard this, so I'm not going to belabor the point, but ultimately the protein folding disorder of amyloidosis is what we're here talking about today. I think this timeline is really helpful, and it put things in perspective as I was starting to think about, the importance of understanding this. Whereas, as you see at the bottom there, the median days to diagnosis, 4 years or so prior to diagnosis of ATTR amyloidosis, people are having carpal tunnel syndrome. And you saw Dr. Schulman's personal example, which sort of fell right in line with this, maybe a little bit off on the timing, but pretty close. And you start to see some of these other physical manifestations. But what we deal with tends to be at the leading edge. Now, you'll certainly have some family history issues, and some of the patients will present with other manifestations. But this timeline puts in perspective why what we do can be so important for this, obviously, clinically substantially impactful disease. As you just heard a bit about cardiac amyloidosis, it's due to one of the two proteins that the amyloid light chain is this medical emergency. It's sort of a totally different animal, but of course, diagnosing it is critically important. And ATTR is far more likely to be what we come across in the hand surgery world from the biopsy results and everything else. But just being familiar with those two types and the terminology, I think, is helpful when starting to think about amyloidosis in general. This is a similar, if not exact same slide that Dr. Schulman had, but again, putting in perspective some of the demographic pieces. So the familial ATTR, where African Americans are carriers of this. And so that's a cohort that I think, and you'll see in some of the data I'm going to present shortly, that's a cohort that's been sort of understudied, partly because of just where the studies have been done, and the nature of some academic work tends to have underrepresented groups. And I think that that's one of them, which is why I think some of the percentages and rates or things are evolving as we understand more about amyloidosis as related especially to carpal tunnel. But then again, seeing this sort of distribution both in demographic variability, but also just how many patients have it. And again, back to the multi-system disease, just how it affects everything. And in many ways, carpal tunnel is sort of the tip of the iceberg or tip of the spear with regards to figuring out whether people have this. It's also one of the easiest ways, sort of through a biopsy at the time of carpal tunnel release, is so much easier than, as you heard, previous uses of cardiac biopsy and far more invasive things. So all that considered, this leads us to the whole discussion around hand surgeons, carpal tunnel syndrome, and amyloidosis. Oh, sorry about that. The musculoskeletal clues. So I'm going to focus on carpal tunnel, and then Dr. Blazer is going to talk about some of these other areas. But bilateral carpal tunnel syndrome tends to be the most strongly associated. Trigger finger, especially of multiple digits, especially with carpal tunnel syndrome, tends to be a red flag issue. And then some less common, but certainly important things to consider: ulnar nerve compression, but at Guillen's canal, people with spontaneous flexor tendon ruptures, and then what we call the shoulder pad sign, or this deltoid swelling that can occur from amyloid deposition. So going right to it's a little bit out of order, but it's actually how a lot of people first encounter it. You may have had examples or times where you've been operating on a patient and you sort of just do this carpal tunnel release. Either it's endoscopic and you're seeing it through the endoscope, or even at the time you enter. And certainly with open carpal tunnel, you'll have had this where there's this thickened synovium that's really waxy and a bit unusual. The tendon sheaths tend to be more fibrotic. The tissue is a little bit rubbery. You don't have to have all these. You don't have to have any of these for it to be amyloid. But if you're seeing these and your suspicion is high, regardless of what I'm about to present on criteria and diagnostics and things like that, taking a biopsy is relatively low risk. And personally, and sort of what the data will tell you, taking a biopsy in the scenario is clinically quite justified. Moving beyond the intraoperative, just really unusual synovial fibrotic sort of findings, I think it's important to understand what the biopsies are. And so again, this is a little bit out of order, but I'll go back to this at the end of the talk. But this comes up a lot. And so I think that the repetition of discussing this twice is kind of helpful. So first is, what tissue do you take? And you'll see reports of both transverse carpal ligament as well as tenosynovium. You'll also see people take perineural tissue. I think that probably has a slightly higher risk of neuritis. And so most people just do the transverse carpal ligament and the tenosynovial biopsy options. But either is adequate, and I'll show some data to support that. How do you send it? So there's a lot of concern, especially from the OR staff. Does it need to be fresh? How do you preserve it? It can go on formalin. It's totally fine to put it on formalin and have it processed in paraffin embedded slides like any other biopsy. And the stains, should the pathologist ask, although I think all pathologists know about it if you just say rule out amyloid, but you're looking for Congo red is the most common, and thioflavin or thioflavin S is the other option that often gets used and cited in the diagnostic algorithm. So I think those are just pieces that I think are valuable to know and sort of have in your mind. Again, if you run into that unusual scenario, you're in the OR, this just kind of comes up, at least you're familiar. Systematically, though, I do want to talk a little bit more about what's out there from a literature perspective and this relationship between carpal tunnel release and cardiac amyloidosis. So you will see a big change in a lot of the available data, 2016, 2017, 2018, starting in the cardiology literature. This study was trying to understand the prevalence of amyloid and concomitant cardiac involvement for carpal tunnel syndrome patients. So it's a cohort of 100 patients or 98 patients, undergoing carpal tunnel release of men and men over 50 and women over 60. And that number comes from some previous data that suggested that those are the age ranges where you start to see the carpal tunnel findings of amyloidosis. In this cohort, 10 patients had amyloid, so it's 10% or just over it. And you see the variations there. 7 were ATTR, 2 were AL. That's the really critical type, and 1 was untyped. And 3 of them ended up being treated. So 2 with cardiac involvement, 3 getting treated. So these are the types of papers, and there's a handful of them, but this is coming out of the Cleveland Clinic group, and Bill Seitz was very involved in it, and I think he's really the one who brought it over into the hand surgery world for a lot of us. This is some of the early data that started to say maybe this is something we need to pay more attention to. This is a really nice study looking at patients who were screened 5 to 15 years after they had surgery for bilateral carpal tunnel syndrome. This is the workflow, ended up with 125 men, 125 women included. They were pretty strict with their criteria. I think it was a very well done study with regards to how strict the criteria were, but certainly some of it's also just capturing patients 5 to 15 years after surgery is not easy. But overall, the cohort they had was pretty robust. And ultimately what they found, again, just about 5% of them had ATTR, cardiac amyloidosis. The males had a higher percentage. But as you start to refine the cohort, you now see a 21% in males that were over 70 with a BMI under 30. And actually, if you refine it even further, those who had no occupational or exposure type risk factors for carpal tunnel syndrome approached 30%. Again, these are the kind of data that start to form the diagnostic criteria that we think about, or the biopsy criteria that we think about. And so I think this is a good background, and I'll get to those criteria in a few slides. But again, thinking about who the cohort is. So slightly older carpal tunnel patients, men perhaps a little earlier than women age-wise. And then as you get a bit older, the lower BMI, no real other exposure risk for carpal tunnel, and yet they're with bilateral symptoms, and that tends to really increase the incidence and perhaps the demographic overlap of cardiac amyloidosis. This is the Cactus trial, where they looked again at sort of wild type cardiac amyloidosis and carpal tunnel syndrome patients. This is 8%. And the patients with it had less structural and functional cardiac involvement than the control. So I think, again, a bit of a mixed milieu of patients, which again just supports the value of being able to diagnose this at the time of carpal tunnel release. And then again, this is called the actual study, and I think we saw some slides about this before, but ultimately, you know, again, helps refine the cohort. Again, it's a 50-patient cohort, so not a huge population, but the prevalence was 4%. But as you get to bilateral patients with left ventricular hypertrophy, 33% of them had it. And so again, it's refining that cohort a bit. So focusing on hand surgery after a bit of background from the cardiology literature. So this is the paper that I think really brought this to the forefront in hand surgery. I think there were perhaps some mentions of it before, but this is really the first paper in the hand surgery literature that at least I ever really referred to out of the group in Cleveland with Bill Seitz. And they really put out these tier 1 and tier 2 criteria. So again, this is informed by so much of that background data from the cardiology literature, but again, you see them here. And it's 2 characteristics from tier 1 or 1 from tier 1 plus any of them from tier 2. So it's the age, it's bilateral carpal tunnel symptoms, or prior release, meaning you're seeing them for carpal tunnel on one side and they had a release 5 years prior, which I think happens to all of us very commonly. And then the tier 2 are some of these other conditions that we think have a lot of clinical overlap. So spinal stenosis, a previous bicep tendon rupture, AFib or flutter, pacemaker, any version of CHF, congestive heart failure, and then of course a family history. And then this will lead you to tenosynovial or TCL tissue biopsy with the staining we discussed before, Congo red or thioflavin, but it's just, I think, easier to remember Congo red because just remember one thing. And then from there, if positive, this often then gets sent off for our lab. It's Mayo. They get sent off to, I think it's most places send it to Mayo for amyloid typing. And then again, I think referral to a to an amyloid expert is very valuable at this point and very important. This is another paper that came out in the hand surgery literature, again, looking at the cohort. I think this cohort, interestingly, shifted the ages all up a bit. As if you remember, the criteria were age 50 for men and 60 for women. But really here, it's looking like it starts to really show up in men at 60 and women at 70. I think, again, we're working to refine some of these diagnostic parameters and biopsy guidance parameters. But I think this is really interesting to see that. But again, you've got almost 30% with amyloidosis in the tenosynovium, which, those are big numbers. So this sort of then moved us, and I think Chris Grandizio, excuse me, and at Geisinger has done a lot of really good work. And so the next 3 or 4 slides are all work that he's been putting out. He trained with Bill Seitz and has really moved this forward. And so I give him a ton of credit. He and I have collaborated on a lot of work, and some of the data are coming out soon. But I think that the available papers now really have been led recently by Chris Grandizio, and he deserves a lot of credit for it. This was one of the, I think, first really helpful papers that came out that showed that the transverse carpal ligament, that showed that 13% were positive, but looked at endoscopic versus open carpal tunnel. Now, I think that this is a really important question. This comes up a lot. I do a lot of endoscopic. Can I biopsy it? The answer is yes. However, the hit rate from endoscopic was much lower. And I think that really opened some questions about whether the tissue right at the incision site there, the sort of tenosynovium that you can get right from the endoscopic entry site, whether that's good enough, whether you get legitimate TCL biopsy from this, or whether you need to adjust the approach. So again, I think endoscopic, it's doable. And I don't know that we should change how we do carpal tunnel releases because of this, but I do think it's important to consider and important to do our best to get as good of a true transverse carpal ligament biopsy, or at least tenosynovial biopsy from within the carpal tunnel to improve these numbers. I think this was another really helpful paper that looked at the comparison of the tenosynovial and transverse carpal ligament. And ultimately, in 150 cases, they saw that the positive rate was pretty darn close. And ultimately, they had 93% agreement, which said, in general, it's probably okay to just take one. I think that's both a safety issue, but mostly a cost issue and a resource utilization issue. Because I think on the back end, thinking about if we just biopsy every carpal tunnel patient that meets criteria, even if the positivity rate is 10, 15, 20%, that's a lot of negative biopsies. And there are costs associated with those. And so taking multiple biopsies in the same patient, of course, astronomically grows those costs. And I think this is a really helpful study that says, take what kind of comes to you. If there's transverse carpal ligament right in the field, that's really easy to take. Sometimes it can be stuck or a little bit retracted after release. If tenosynovium is there, that's also adequate. And I think this is really helpful to know as a surgeon entering, the OR trying to make this decision. And this is sort of the other side of the coin, which is they looked at bilateral biopsies. And bilaterally, they were negative in 57 out of 65. So again, 65 patients, not a huge cohort. But I do think it was very interesting that out of the 8 that were positive, 2 of them were bilaterally positive, and the other 6, so 75%, were not concordant, meaning they had a biopsy that was in the first surgery that was positive and the second surgery was negative, or first biopsy was negative and second was positive. And ultimately coming out of this, it's if the first one you take is positive, you don't need to repeat it. But if you're doing bilateral release, then and the first one is negative, consider the value of taking a second one because that may actually still identify missed amyloidosis from the first time. It certainly raises questions about the overall miss rate. Certainly is attributes some of the variation in cohort numbers, and we don't really understand that at all. So I don't have much to add except to say that it's a problem. And I think there are some people working on how to figure out biopsy hit rates and optimizing biopsy, et cetera. And there's some data that shows some holes in this. Like I just said, I mean, I think, again, you're still seeing the positivity rate being high, but a lot of the things that you'd expect. So so many of the bilateral patients, 55%, weren't amyloid positive, whereas, of the amyloid, excuse me, the bilateral patients were still the dominant in the amyloid negative group, but in the amyloid positive group, it was also quite predominant there. And then you have the trigger finger patients in there. Again, there are associations, but it's not a guarantee and it's not this direct link. And I think it's really important to understand that. And I think, again, here on the bottom right, this was a far lower hit rate overall, where you had some positive Congo red testing, but very little cardiac involvement and overall lower numbers than in some of the others. And with the trigger fingers, that association was not as strong as previously published. So I think, again, we're refining our understanding, but it's really important. Things we need to understand, especially as number 1 and number 2 on this, is what is the true prevalence and significance of amyloid, clinical significance of it in carpal tunnel syndrome, and then what % of them convert to cardiac disease. Because I think that really informs the risk-benefit trade-off, the cost trade-off, the biopsy decision-making, all that. And then certainly, if it's detected, what should be done? We talked a little bit about that. The other 2 pieces are kind of, I think, out of our zone of expertise. And in summary, it's a problem. We just don't know how big of one. So right now we're all thinking about it. It's growing in importance. We're deciding on biopsies. I think these criteria are a good guide for tier 1 and tier 2 biopsy criteria. And I think if you follow these and use these to sort of inform the start to doing this, you will likely have a reasonable justification for it clinically. I think patients understand it somewhat well. And I think as a clinician, we're always trying to be guided by good evidence. And I think this is about as strong of evidence as we had. I do wonder if some demographic variability needs to be added to these criteria, especially as we see some of the African-American predominance of these genetic markers, but that's an evolving science. And then again, remember, you can send transverse carpal ligament or synovium. You can get it from open or endoscopic, but endoscopic right at the incision site may not be as good, and we're working on figuring that out. It can be put on formalin, does not need to be fresh, and Congo red stain tends to be the common one, but thioflavin is also an option. Thanks so much.
Awesome. That was a great summary. Thanks for that. Maybe just while Dr. Blazer's pulling up his slides, you can answer one thing. So I do endoscopic as well. The way I've been dealing with that data that came out from Grandizio's paper, and I know you have that paper that just came out with like the decision-making endoscopic versus open, and I know this isn't in it, but maybe in a future one. But I've been doing the first one endoscopic. If it's negative, then kind of telling the patient maybe we should do the second side open. How are you dealing with that?
Yeah, I'm a little bit benefited by the fact that I have a practice that is predominantly open carpal tunnel, largely driven by procedure room and wide awake, and we just don't have that as easily doable endoscopic. So my answer is a little bit biased by that. Your approach is the one that I've used in patients who I think have any of those tier 2 criteria. So in patients who I think have, to me, age and bilaterality, I get it, but it's a little hard to convince, that 52-year-old laborer to have an open carpal tunnel when they're really concerned about that palmar incision. So I've just explained to them, I think that there's a concern here. We can get a biopsy. It may be lower with endoscopic, but in any patient who I think is amenable to it, I think your approach is great. Start endoscopic, do that biopsy. If it's positive, we're done. If it's negative, discuss the risk-benefit trade-off. I think that's a really, really wise approach.
Great. Thank you.
I also would add, they do They did a distal first. I do a proximal first. I actually think from proximal first, you can see the biopsy better. My rates, my disparity, my sort of rates of biopsy positivity were much better than what they published, which we're actually getting ready to publish now. We still need to sort of combine, but I think that there's maybe, again, some issue around the tissue that you take or the endoscopic, which we're trying to figure out a little bit better as well.
Interesting. Looking forward to hearing about it. All right. So it's my distinct honor to introduce Dr. Philip Blazer. He's the division chief for the hand and upper extremity surgery at Brigham and Women's Hospital. He's the program director for Harvard Hand and Upper Extremity Fellowship. And during my fellowship at MGH, he was oftentimes the most meaningful contributor at our citywide journal club. So Dr. Blazer's contributed to the orthopedic literature in a variety of topics, including amyloidosis. And so we're lucky to have him here. So thank you, Dr. Blazer.
Thanks, Nikhil. Lovely introduction, and really nice to follow two very strong speakers. As we move into amyloidosis for the hand surgeon, other than carpal tunnel, you'll see that there's actually quite a bit less literature on these topics. So there'll be a lot more level 5 evidence. And that's just the nature of it. So that's kind of the way it will go. And I want to thank my colleague, Dafang Zhang, who has led our research efforts here in Boston on amyloidosis. And again, as Dr. Shulman mentioned, this is in today's New York Times, so incredibly timely for everybody. Quickly, just to review, we went over this a lot, the overview of amyloidosis. It's a disorder of misfolded proteins. There are over 30 proteins that have been identified that can contribute, but the vast majority are the ATTR, transurethrin wild type or mutant, or the AL, which is a misfloated immunoglobulin, light chain derived. And you can see in the cartoon at the bottom that this can have myriad effects throughout the body. But obviously, we're mostly interested in the hand. But as Dr. Shulman mentioned, the probably most impactful aspect of amyloidosis is the cardiac disease. From the hand surgeon's perspective, this is a restrictive cardiomyopathy. You can see the pathology specimen here with the highly thickened walls of the heart, also some arrhythmias. And a lot of the data that you review on this is all about the mortality associated with it. Many of the studies show that when patients present with heart failure with amyloid untreated, particularly if they have the AL variant, the light chain, their median survival is 6 months. The ATTR survival in some studies is 4 years. So clearly a disease with significant impact on our patients. And again, what's happened in the last decade, the association between amyloidosis and carpal tunnel is not new. My hand surgery fellowship in the mid-90s, I remember hearing about this, but it was sort of well, there's not much to do about amyloidosis, so why are we biopsying these folks? But as Dr. Shulman went into, really in the last decade, significant medical therapies have become available. The first one that I saw that was FDA approved is daratumumab, which was initially approved for multiple myeloma just about a decade ago, but specific things just in the last 7 years. And again, here is the article from the New York Times. So Avi talked a lot about carpal tunnel and amyloidosis. A couple of quick highlights. Some of the studies show that with the ATTR variant, around 2/3 of patients have carpal tunnel, and it precedes the diagnosis of cardiac disease by 4 to 7 years. And here is just an image of, for those of you who have not done the biopsy, just what's involved. This is obviously a mini open carpal tunnel release with a mosquito hemostat grasping the tenosynovium before it's going to be excised. We talked about some of the histology, and Avi talked about how you can do the tenosynovium or the transverse carpal ligament, the Congo red staining with the apple green birefringence, when you can see the staining above and then the birefringence below. And as was mentioned previously, once the biopsy is positive for amyloid, it needs to be typed. And that is done only in a few very specialized centers. Our place sends it to the Mayo Clinic for biopsy. So what are the other musculoskeletal manifestations of this disease? Probably the non-musculoskeletal ones that are most common: cardiac, renal, neuropathy, and GI I've put on the left. But the stuff that's worth talking about, I'll be touched on a little bit, but that's on the right of the slide: carpal tunnel, trigger finger, biceps rupture, rotator cuff disease, and the lumbar spine, going in order from the hand surgeon's perspective, from distal in the upper extremity to proximal to the spine. So what is there about trigger finger and amyloidosis? And unfortunately, there is not a lot written about it. There is, going back to 1980, a case report describing this, a patient who had triggering of the FDS, or rather at the FDS decussation, as well as at the A1 pulley. So this was a patient who the surgeons, and this was published in PRS, as I said, in 1980, had to go distally, as many of you have had to do on occasion, to get the finger to glide under the remainder of the pulley system. And subsequent literature on this is limited, but available literature suggests that this is that phenomena that we all see sometimes, where there are multiple digits involved, bilateral hands, and the trigger finger may co-occur with carpal tunnel syndrome. If you look at some of this literature, I think this is less of an idiopathic trigger finger. This is more of an idiopathic tenosynovitis. And so I think this is, excuse me, or the patient that my antenna goes up for is somebody with more of a tenosynovial proliferation than we typically see with a idiopathic trigger finger. And here is an image of doing a biopsy, and this is not necessarily the image that we see that has a high probability, but nevertheless, this is someone who we did elect to do a tenosynovial biopsy, and as you can see, the tendons are gently brought up, and there's always a tiny bit of tenosynovium, and you don't really need very much tissue for the pathologist to be able to test it. But some of the findings that have been described include that the A1 pulley is thickened, but that's true pretty much in all trigger fingers. The thought is that the amyloid is infiltrating the flexor tenosynovium, so it is like a tenosynovitis, like a RA type of trigger finger where there is thickened tenosynovium. Some authors have described more of a light brown or greenish brown intraoperative appearance of the trigger fingers, and there's just a bulk effect. Tenosynovectomy may be more of what the surgeon is actually doing. So this is, again, as I said, the person that my antenna go up about, maybe I should biopsy this and look for amyloid, is when I'm doing more of a tenosynovectomy rather than just a pure A1 pulley release. And the literature, like in carpal tunnel, says you can biopsy the tenosynovium or the sheath to the A1 pulley. So getting at that question, which patients with trigger finger should we biopsy? There really is a paucity of evidence. We're still figuring out in carpal tunnel, as Avi talked about a few minutes ago, but with trigger finger, there's even less evidence. And so what am I doing? What's my level 5 data? If I think there's an abnormal amount of tenosynovium without a specific diagnosis of rheumatoid arthritis or something else that should lead or typically leads to a tenosynovitis. The age factor, I think, has been investigated in carpal tunnel, and I suspect that is also true here. And so typically patients in a somewhat older age than we typically see trigger fingers, 65, 70, what have you, while that's certainly a percentage of the folks with trigger finger, it's not the average age we see. And then some of those trigger finger releases where because of the amount of tenosynovial and tendon visual macroscopic change, you end up thinking about excising the slip of FDS. Interestingly enough, our paper this year in JHS found that trigger finger was actually helpful as one of the factors that could lead to a different amyloid risk score, indicating which carpal tunnel patient should be biopsied. And this cartoon is what we've made summarizing our data in that article that I have referenced here that my colleague Dafang Zhang is the first author. But using our risk score, we are biopsying men over 70 in general, and this is for carpal tunnel. But if the patient has a previous history of a trigger finger or current history of a trigger finger, we're lowering our age to 60. And likewise for women, we set the age at over 80. But if they all had a trigger finger as well, that brought the age back to 70 in terms of our risk score recommending who should have their carpal tunnel biopsy. So clearly there seems to be some kind of association. So moving on to the biceps tendon, the literature says the distal biceps tendon rupture. And these folks typically are not the standard middle years, 40-year-old patient who had a large eccentric load applied to the forearm and hand, leading to the rupture. This is more of a older age group, and as you can see, some of the studies have shown that, while not quite as common as carpal tunnel, but in the ATTR variant who have heart failure, a third of them had a rupture. And this is a paper, and these are images from that paper by Geller and Jama, looking at that. And likewise, the biceps ruptures preceded carpal tunnel syndrome by a significant number of years, as you can see here. The qualification to this that I think is interesting is that I think with this bruising here and the image on my right, patient 2, that certainly looks to me like they may be a distal biceps rupture. But the other patient they included the image, I think this is likely to be a proximal long head of the biceps tendon rupture. So I would suggest that this not be thought of as distal biceps tendon rupture, but really rather biceps tendon rupture. And that fits with what is seemed to be known with the deposition of amyloid fibrils into muscles and tendons. There are some other shoulder manifestations that are worth being aware of. A high percentage of people who come to the cardiologist with heart failure who end up being diagnosed with amyloidosis complain of shoulder problems. The two most frequently associated are dialysis related and systemic ATTR. There is written this shoulder pad sign, which is suggestive of amyloid infiltration. And you can see here, this is a relatively slender individual, however, with this big, quote, shoulder pad type mass around their deltoid. There is a risk of atraumatic rupture, not only of the biceps tendon, but also of the rotator cuff. And when you see some of these findings, particularly in patients in the appropriate age group, you may want to consider imaging of the shoulder and biopsy. Imaging, and this is a fairly dramatic example taken from radiographics, but in the MRI, you can see thickened tendons and deposition in the deltoid muscle here. You can also see deposition in the joints and in the bone of the humeral head here, and this can progress on to shoulder capsule obliteration later in the disease process. Surgical treatment can be indicated when these folks fail non-surgical management, and if their cardiac disease is in an appropriate status to make them operative candidates. Typically, that's a synovectomy, biopsy, and debridement. That can be done arthroscopically, as you can see here through this image. Arthroscopic repair for a rotator cuff or a biceps tendon, as indicated. But with the amount of infiltration you saw in that MRI, there are certainly patients that the appropriate surgical treatment would be an arthroplasty. And then lastly, we get fairly distant for the hand surgeon, lumbar spinal stenosis. Fortunately, I don't see much of that. But amyloid clearly can deposit in the ligamentum flavum along the spine. Typically, the clinical presentation for these folks is more of a spinal stenosis picture rather than a herniated disc. And it's that thickening of the ligament which causes stenosis. There is likely some value with biopsy of the ligamentum flavum in spinal stenosis, but that research is honestly still being done. And once again, this is another area where there is some literature, but not a whole lot to guide us. And for this group, probably not terribly relevant of exactly who should get their ligamentum flavum biopsy. So what is our role as hand surgeons in 2025? Well, clearly it can be that of early detection. I think recognizing the red flags, age, trigger finger, bilaterality, as Avi emphasized, as well as the previous biceps rupture, and then biopsying the high-risk patients if it's a carpal tunnel release, a trigger finger release, or a shoulder procedure that is relevant. I think, as Avi suggested, over the next few years, there's going to be a lot more evidence-based answers to questions that we don't really have terribly strong evidence for at the moment. Really, which patient should be biopsied? I think there's a lot of research on this, but we don't have a clear consensus for carpal tunnel, and there's nothing remotely approaching consensus for trigger finger. We talked about the type of tissue, but another issue is, does the amount of tissue matter? I do wonder if the data Avi mentioned on the higher positivity of the open carpal tunnel release is a phenomena of increased tissue volume, which is more easily obtained with tenosynovium at open biopsy than endoscopic for many people. And then in terms of trigger fingers, are there visual cues that are reliable that's going to increase the probability of positive results? Or is it just past medical history and demographic? What is the cost? Because clearly there's an added cost to doing the biopsy. And then if you think about how many patients you need to biopsy, in our recently published study, we biopsied over 300 patients. And in the first year, we had one begin on medication. Now, we know from the data that most folks are going to develop their cardiac problems 5 to 10 years later. So this is about early detection. But what is that cost going to be? And you know, is there a false negative rate? We talked about the concordance and discordance between biopsies between the two sides. And then for hand surgeons in particular, when we have a patient with a positive result, what should we do? The options I can think of are bringing them up with their PCP, cardiology referral. A fair number of them, it would be appropriate to consider neurology. I can tell you anecdotally from colleagues of mine who I've spoken to about this, I think this is similar to the distal radius fracture bone density phenomena that has impacted our community, that Tamara Rosenthal has published on 15 years ago, that if you order the test, it is much more likely to have something done than if you send the patient to their PCP. And I think that is true here. If you send a letter to the PCP, I think you're much less likely to have a further workup done than if you actually refer to a cardiologist or one of the amyloid heart failure or amyloidosis cardiology groups that specialize in that, or even just to a cardiologist in general. So lots of remaining questions. Thank you for your attention, and here's some of the papers that are in the limited literature on this topic.
Great, thank you so much, Dr. Blazer. We certainly have a lot more to learn about the topic, especially in this way. It's interesting when you think of pathophysiology, we know it's easy to wonder why things like cubital tunnel, de Quervain's, and all these other things, maybe we just need to find out whether or not these may also be related. But thank you. We are right around 9, so just be respectful to everyone's time. Thank you, Dr. Blazer. Thank you, Dr. Schulman and Dr. Galati for those outstanding talks, great discussions. I'm going to hand it off to Dr. Hammert.
Yeah, I echo that. I'd like to thank our moderator and all of our presenters. I think there were many excellent pearls tonight that we can take home and utilize with this going forward. I'd like to thank all the attendees for attending the webinar tonight. This will be recorded and available on the American Association for Hand Surgery website. And please keep update with our schedule and tune into future webinars for us. Thank you, and everybody have a good evening.